All right. Well, perfect, everyone. Thank you so much for joining for our final educational course of the So Do We season. As you know, we wrap up in a couple of weeks. So we're very excited to have another great guest speaker joining us today. So we have Sarit Fleishman, who is a clinical practice and education specialist with the University of Maryland Medical System. She's going to share some very important topics when it comes to the cancer realm. So I'm going to go ahead and kick things off and hand it over to Sarit.
All right, thank you so much, Andrew. As he said, my name is Sarit. He gave the fancy title, but I am basically the nurse educator in the Cancer Center at University of Maryland here in Baltimore. Um, and I am going to present cancer treatments and talk a little bit about the different types of cancer treatments and also kind of some of the things that we think about with patients after cancer treatment as well. As Andrew said, I do cover a few sensitive topics. So if you need to leave, please feel free to do so. Also, if any of these topics hit hard or trigger warning, and you need to seek additional help or assistance, please do so as well. I am going to share my screen. It's a little finicky. So if you guys at any moment can't hear me, please let me know. Can everybody see my PowerPoint?
Yep.
Okay, perfect. So before we talk about the different types of cancer treatments, I want to very quickly talk about screening and prevention as well. So every year we look at cancer, we look at how cancer what cancers are more prevalent or less prevalent and have new best practices. So something always changes. And we always have different new guidelines regarding screening and regarding prevention as well. So, screening is completing routine tests, and the point of screening is to detect cancer as early as possible in order to be able to remove it before it becomes a bigger problem. Screening can be done at the doctor's office with imaging tests, blood tests, stool tests, but it can also be done on your own. So we usually tell young adults around when you're a teenager and you're going through puberty, for females, start doing monthly breast self evaluations. For males, we tell them to start doing testicular self evaluations every month. You know, try to feel for lumps and bumps or see if there's anything new or different that you need to talk to your doctor about. Because if somebody does get cancer and they can find it with a lump or bump, hopefully we can get rid of it as soon as possible. And then prevention, we look at minimizing modifiable risk factors. So we're looking at things like smoking, obesity, our eating habits, our exercise habits, where do we live? We look at microplastics. Microplastics is really big now, and what is the effect of those forever chemicals? So this is a quick picture of some of the screening tests. I wanted to really bring this up because there has been a rise in the last couple of years for younger adults with colon cancer. So colon cancer was the type of cancer that we heard about for older people. We used to say you don't need to get a colonoscopy until you hit 50, but now we're seeing it in younger and younger people, probably because we're eating more red meat, we're eating more processed foods, we're not exercising as much as a population. So we're starting to see these in younger adults. So just wanted to bring this up as another point as we go through this, that cancer can happen at any age. Unfortunately, it does not discriminate. So when we talk about cancer treatment, we talk about different goals. So the number one goal for cancer treatment is to get rid of it entirely. We call this a curative intent. However, sometimes we cannot do that. Either the cancer itself, we know we cannot get rid of it because of the type of cancer, or with what else is going on with the patient. In those cases, we will do life extending or symptom management to try to prolong the life or relieve the symptoms that the cancer causes. Once we do cure it, if that is the intent and we are successful, sometimes the patients will stay on some type of a treatment in order to prevent the cancer from coming back. And that is called maintenance treatment. So if they are a maintenance treatment, they could be on the same type of treatment that they were when we were trying to cure, or they could be on something slightly different. And then I also wanted to bring a couple of other terms, adjuvant and neoadjuvant. So sometimes we will do different treatments in a specific order. So we might do adjuvant therapy, where we do something first in order to get rid of the bulk of the cancer. And then we will do something else to lower the risk of the cancer coming back. So, similar to maintenance therapy. So, for example, we might do surgery to get rid of the tumor, and then we will do chemo and radiation on the off chance we didn't get rid of 100% of the tumor and some of the cells escaped. That way, we are making sure that we're lowering the risk of cancer coming back. Neoadjuvant is we are doing some form of a treatment before our primary main treatment. So in this case, we could do chemo and radiation to shrink the tumor to make it easier to then go in and get surgery and be able to remove all of it. All right, so types of cancer. So as we're talking about it, I wanted to talk about the different hallmarks of cancer cells. So cancer cells can multiply limitlessly. They do not have the signals that normal cells have to stop growing and stop multiplying. They escape cell death and they escape the immune system, form new blood vessels, and that is how they spread to other parts of the body and how they take away normal cells nutrient and oxygen supply, because and that's how the tumor keeps getting fed. So the first type is chemotherapy. This is probably something that's most commonly known, most commonly seen in the media. So we use medications to kill fast-growing cells. This is the most common type of treatment. We usually give it as an infusion. The patient either comes into the hospital, into an inpatient room, or sometimes they'll do it outpatient, meaning they come in for their appointment in the clinic or in the infusion center. They get their treatment and then they go home. Common side effects of chemotherapy is for other normal rapidly dividing cells. So the reason that chemotherapy causes hair loss, causes mouth sores, nausea and vomiting, and diarrhea is because those cells in our body also multiply very quickly overall and grow very quickly. So chemotherapy impacts those cells more than other cells. That's not to say that chemotherapy will not cause other side effects. It can cause a lot of other side effects. It can cause fatigue. It can cause a higher risk for infection or bleeding because all of our blood cells are also fast growing cells. So that gets reduced as well. And then the specific medications have specific side effects and specific toxicities. So this is a picture we show the nurses when we talk about chemotherapy. We call them chemo man or chemotox man. So this is an example of how different types of chemotherapies cause different toxicities. So for example, cytarabine up at the top in purple can cause toxicities of the eyes. So we will give patients steroid eye drops to prevent the vessels from getting as much chemo so that any kind of side effects are reduced or prevented. With cisplatin and carboplatin, we have ototoxicity, which means the ears. So the patient could have hearing loss or ringing in their ears. Cyclophosphamide and ifosfamide has something called hemorrhagic cystitis, where it is inflaming the bladder and can cause bleeding and burning sensations when they pee. But you can see every organ can be impacted. You can have your lungs, the heart, cardiotoxicity, numbness and tingling in their fingers and toes. They can have their liver can be impacted, their kidneys can be impacted, their bones can be impacted. Then we have radiation. Radiation is probably the second most commonly known type of cancer treatment. There are a lot of different subcategories of radiation, but they basically fall into the three types that I have listed. So we have external beam, which is probably the most commonly known, where we use rays to kill the cancer cells. And we can use different types of rays. We can use photon therapy, gamma therapy. We can also use proton therapy. This is a little newer and it's more precise. So it is less likely to damage normal cells. We also have brachytherapy, and that is internal radiation. So, this is when we are putting inside the patient's body seeds or rods as close to the cancer as we can in order to kill the cancer. Sometimes when we do this, the radiation seeds and rods are always radioactive until we take them out. There are other circumstances where we will put the seeds or the rods into the body and then take the patient to the radiation room and beam those seeds or rods. And in those cases, the patient is only radioactive when we are actively giving them radiation. And then the last big kind of umbrella type is systemic. And that is when the patient is actually getting a radioactive substance that then travels throughout their body. So they are either taking a radioactive pill or we're giving them an injection through an IV or like a shot. There's steps for radiation. We have a radiation oncologist. They do a consult with the patient. Either the nurse or the oncologist will do an education with the patient. They're going to determine the best type of radiation for this patient based on what is going on with them and what cancer they have. And then they need to do imaging. So they need to really see where the cancer is. And they need to do what's called the simulation, which is basically mark where we are going to go with the radiation so that we don't accidentally give radiation to the wrong part of the body. And then we have the treatment. And usually the treatment is not given all at once. We do what's called fractions. So the doctor might say, oh, the patient needs 100 gamma rays. I'm just going to make up a number, but we are for 4 weeks. So that way we are lowering the dose each time so that the side effects are not as severe rather than giving it all at once. The side effects, again, depend on rapidly dividing cells and also where the radiation is occurring and the type of radiation. So, a lot of patients will have nausea. A lot of patients can have hair loss, especially if they get like brain radiation or radiation to their head or neck. Usually, no matter where the radiation is, there will be some kind of a radiation rash. So, redness or burning sensation. So this is a quick video, about 4 minutes, about radiation for you guys. Let me know if you can't hear it.
Today, we are going to talk about radiation therapy, also called radiotherapy, which is a treatment commonly used for cancer. The goal of radiation therapy is to destroy cancer cells. This is done by using high doses of radiation to damage the DNA inside cancer cells. Unlike healthy cells, these cancer cells cannot fix the damage and will stop growing and die. There are many different types of radiation treatments that may be used alone or with other therapies, such as surgery or chemotherapy. A doctor trained in treating cancer with radiation, called a radiation oncologist, will help choose the best course of radiation therapy for you. The most common type of radiation therapy is called external beam radiation, which uses a machine to deliver beams of radiation from outside the body to the cancer. This is usually done over a period of daily treatments. If you are receiving external beam radiation, you will have an appointment called simulation or mapping, where you will have a CT scan and the best body position for your treatment will be found and recorded. A special device, such as a body mold or mask, may be made to help keep you in the same position for all your treatments. You may also be given small tattoos. Your radiation oncologist will use the CT scan taken at this appointment and work with a team member trained in radiation treatment planning, called a medical dosimetrist, to create a treatment plan for you. A medical physicist will then complete safety checks before your therapy starts. A member of your care team will let you know if you need to follow any special instructions for treatment, such as taking medication or changing your skincare routine or diet. If you are given directions, it is important that you follow them carefully. When you arrive at your first treatment appointment, please stop at the front desk. A team member will explain the daily check-in process to you and show you where the changing rooms and lockers are if you need to change for treatment. Regardless, we recommend you wear comfortable, loose-fitting clothes and leave jewelry at home. Your loved ones may come with you to your treatment appointments, but will need to stay in one of the waiting areas. You should plan to be in the department for at least 1 hour from your scheduled treatment time and arrive early if you can. A team of licensed radiation therapists will come to get you from the waiting area and bring you into the treatment room when it is time for your appointment. They will help you get into the same position you were in during your simulation. The therapist will go into a different room to control the machine, but will always be able to see, hear, and talk to you. The treatment machine will move around you to aim the radiation beam at the part of your body needing treatment. It may also take some x-rays. You will not see, feel, hear, or smell the radiation, but may hear noise from the machine. Having external beam radiation will not make you radioactive, and you should be able to return to most activities after treatment. Throughout your therapy, your care team will meet with you regularly to check your progress and manage any potential side effects. If you have any questions or concerns, please do not hesitate to ask a team member.
All right, so this is just a quick summary of what we talked about, and we'll keep going. Yay. There we go. Okay, so our next type of cancer treatment is surgery. And this is when we are trying to remove the tumor tissue. As I mentioned earlier, this can be done on its own. It could be done before or after chemo or radiation. Another thing we can sometimes do is something called HIPEC, which is when we go into surgery, we remove as much of the tumor as we can, and then we put lines into the patient, and we give the patient in the abdomen. We then leave it in the abdomen for hours. We jiggle the patient sure the chemotherapy goes everywhere it needs to go, and then we drain the chemotherapy out. And the whole reason that it is hot chemotherapy is the heat will kill the cancer cells and the chemotherapy itself will kill the cancer cells. We can use surgery as a way to treat the cancer, but we can also use surgery in other ways. We can use it to diagnose the kind of cancer the patient has. We can use it to stage it, meaning to see how far advanced it is and how much it's spread. Or we can even use it to prevent cancer. So an example of that would be finding a precancerous lesion, or for a colonoscopy, if we find a polyp and we remove it before it turns into colon cancer. Or sometimes we find precancerous lesions in the breast or in other organs, and we can remove them before they become cancerous. We strive to remove the entire tumor. However, sometimes we can't. Either the tumor is wrapped around an important blood vessel or an important organ where we cannot take all of it out, and the risk of taking the entire tumor out is greater than the risk of leaving some of the tumor in. In those circumstances, the surgeons will take out as much as they can. That is called debulking. And then again, as we said, they're going to use another form of treatment to try to remove the rest of the cancer. And then we're moving to newer types of therapies. So we're really trying to find things that work better than chemotherapy and radiation. Chemotherapy and radiation work very well, but we know that they have really bad side effects. And sometimes our patients can get very sick or even pass away, not from the cancer, but from the side effects of the chemotherapy or the radiation. So we're trying to find newer treatments. Immunotherapy and targeted therapy, which I will talk about in a little bit, are those newer therapies. So if you guys remember, one one of the hallmarks of cancer cells is that they escape our immune system. Our immune system does not recognize cancer cells as dangerous. So immunotherapies help increase that control. So they increase our own immune system so that immune system can work better to target and destroy cancer cells. There's a few examples. There's immune checkpoint inhibitors where they block the checkpoints that normally keep the immune system from being too strong. There's also T cell therapy where we boost the natural ability of killer T cells. And then we have bispecific and trispecifics where we basically have an antibody where it grabs an antigen on the cancer cell and it grabs an antigen from the T cell and it puts them together. And once it puts them together, the T cell now can recognize the cancer cell as foreign and start attacking it and creating an immune response. Side effects of this is really dependent on the immune response that our body creates. Oftentimes, there will be allergic type reactions. So we might see hives, we might see their blood pressure drop, their heart rate go up. We could have fever, or other flu-like symptoms, or we can have increased autoimmune type reactions or inflammation. So this is just an image of all the different immunotherapy side effects. And just like chemo, immunotherapies can hit every part of the body and can cause side effects of every part of the body. So if there's an inflammation of a specific part of the body because of the immunotherapy, then those are the type of side effects that we are going to see. And it really just depends on what else the immune system attacks while it is trying to attack those cancer cells. And then targeted therapy are medications that attack a specific gene mutation in the cancer cells. So every cancer cell has DNA mutations that are slightly different from our own normal cells. And those targeted therapies attack those. So we have done a lot of work on genetic testing and tumor marker testing. So we will do all those tests on cancer cells when we diagnose a patient to try to see if there's a targeted therapy that will work for them. They can help stop the cancer from growing. Some of these genetic mutations create those blood vessels that the cancer cells do help form. So then we stop forming those blood vessels. This is called precision medicine because we are only attacking the cancer cells. So ideally, our normal cells are not being impacted. So examples of those are small molecule medications where they will find a mutation, go inside the cancer cell that has that mutation to kill the cancer and antigens on the cancer cells. And monoclonal and immunotherapy, they work both ways. A lot of side effects of these are side effects that if you have a normal cell that also has a similar mutation or has that biomarker, then that cell is going to be impacted. So a lot of times targeted therapies will cause diarrhea, they can cause blood clotting or wound healing problems, fatigue, skin or nail changes, liver problems, or mouth sores. Hormone therapy. So hormone therapy we will have as part of the treatment along with chemo or immunotherapy, or we can also have it as maintenance therapy. Hormone therapies are specific medications that stop the hormone production that the cancer uses to grow and feed. So this is usually for breast cancer, ovarian cancer, cervical cancer, and prostate cancer. Those cancers are very hormone sensitive. And we will double check, again, very similar to how we do genetic testing, we will look to see are the cancers hormone sensitive. And if they're hormone sensitive and they are feeding on those hormones, we will use hormone therapy to block those hormones. It's usually given as a pill by mouth, but sometimes we'll do it as an injection, so like a shot. And then common side effects are related to the hormone that we are stopping. So it can include hot flashes, fatigue, bone loss, night sweats, and sexual dysfunction. And then we have cell therapy. So we have stem cell transplants. So that is a treatment usually for blood cancers and other blood disorders, where we are giving patients really, really high doses of chemotherapy and radiation to kill the cancer cells. When we do that, we are also killing their bloodlines. So we then have to give them a stem cell transplant to replenish the bloodlines that we have killed in their bone marrow. So we are giving them healthy blood stem cells to replace those damaged ones. If you ever have a patient or a family member that is going through a stem cell transplant or any kind of cell therapy, when we talk about the treatment, we talk a lot about minus days and plus days. So minus days are the days leading up to the stem cell transplant, where the patient is getting those really high doses of chemo or radiation. Then we have the transplant, and the transplant is day 0, and it's usually really exciting. We tell the patient it's your second birthday. We try to have a little party for them if we can, because they are getting new cells. They're getting new stem cells that are going to grow and develop into these new blood cells if everything goes well. So it's a very exciting time. We have 2 types of transplants. We have auto or autologous transplant, where we use the patient's own stem cells. So we will take the patient's stem cells and harvest them. And then we will give it back to them after the chemo. Or we have allogeneic or allo transplant. For an allo transplant, we take a donor's stem cells and then transplant them into the patient after the chemo. So after day 0, then we have plus days. And we talk about plus days in a way where we're waiting to see, are the stem cells taking effect and starting to work? But we are also worried about side effects. At this time, the patient doesn't have an immune system. They don't have clotting cells. They don't have red blood cells. So we're really worried about an infection. The other thing we're worried about is graft versus host disease, which is GVHD. So if a patient gets donor stem cells, the donor cells will sometimes attack the patient's own body because they don't recognize it. And that causes the graft versus host. So we talked about infections, we talked about graft versus host. Symptoms of GVHD really, again, depend on what organs the donor cells are attacking. It can be acute, meaning it's happening on those first 100 days after day 0, or chronic, which is after 100 days. The most common organs that get impacted are the GI. So the patient can have nausea, vomiting, diarrhea, weight loss. The skin is impacted a lot, so they'll have rash, skin redness, dry or tight skin, changes in the skin color, texture, hair losses, nail texture changes. The liver is impacted a lot, so they will have yellowing of the skin and eyes, known as jaundice. And then the mucous membranes is another thing that gets impacted. So that will be dry mouth, dry eyes, taste changes, smell changes. And you have mucous membranes all up and down the GI tract as well. So that can also lead to diarrhea and nausea and vomiting. And we treat it with immunosuppressants. We want to calm the donor cells down so that they are not attacking the cell therapy. And this is a really neat of immunotherapy and cell therapy. So now we're combining treatments. And how this works is we will take the patient's own T cells, or we're now trialing it with donor T cells. We take them to a lab and we genetically alter them to have special receptors called chimeric antigen receptors, or CAR. Those receptors will then be given back to the patient after we give them some chemo, and now these T cells know to attack the cancer cell. So whereas before the cancer was able to evade the immune system and hide, these new T cells have new information and now know to go after the cancer cells. So we have different side effects of CAR T cells, even though they are cell therapy. We still talk about the infusion as day 0, with the chemotherapy leading up to infusion as minus days, and after the cell infusion being plus days. So after the patient gets CAR T cell infusions, there's 2 very specific side effects that we look for. We look for cytokine release syndrome, which is a type of infusion reaction that happens when we have too much cytokines in the bloodstream. So we have a lot of new immune immunotherapy cells. Those cells will release cytokines to help kill the cancer. But when they release the cytokines and we have too much cytokines in our body doesn't know what to do with them. And then we'll have these signs and symptoms. So we will have fever, low blood pressure on our patient, or low oxygen in the blood. We treat the symptoms. We give steroids to, again, kind of calm down the immune system a little bit, or another medication called tocilizumab, which also reduces that immune response. Now, when we first started with CAR T cells, we were really worried about giving people steroids or toci because we thought if we reduce it too much, then the patients will not be like the treatment will not be as effective. We have found that that's not the case. So we really need to reduce that initial immune response, and these CAR T cells will still do the work. The other side effect is neurotoxicity. So these cytokines, the same cytokines I just mentioned, will now go to the brain. So they're causing inflammation of the brain. So the patient's going to have headache, delirium, inability to talk or write, tremors, confusions, or seizures. And again, we're going to treat the symptoms, give anti-seizure meds, and give steroids to reduce that immune response. So one of the things we do is we look at the patient's neurological status. And one of the things we do is a handwriting example, samples every 8 or every 4 hours. So this is just a quick example to show you how quickly patients can deteriorate. So before this, the patient was writing very normally, writing the full sentence. We like them to say, my name is, and I am at University of Maryland. And you can see this is completely we can't read this at all. And the patient, they couldn't talk, they could barely hold a pen, and we did not understand anything they wrote. So they had really, really severe neurotoxicity. The last type of cell therapy is tumor infiltrating cells, or TILs. So this is very similar to CAR T cells. The difference is we go into surgery, we take a tumor sample under surgery, and we find the T cells that are growing inside the tumor. Those T cells are then taken to a lab, grown and isolated, and then given back to the patient after chemotherapy. Because they were part of the tumor sample, those T cells were trying to kill the cancer cells. So by growing them and expanding them, our hope is that they then can kill more effectively. Patients have to go to the ICU for this because they need really close monitoring when we give them IL-2, which further boosts their immune system. And again, very similar side effects, allergy type reactions, flu-like reactions. But here we can also have increased fluid in the body with the IL-2, which can lead to swelling, really fast weight gain, trouble breathing, low blood pressure, and organ failure if we're not careful. And then clinical trials. So clinical trials is when we test new medications or combinations of medications against current treatment. So we want to see, how did we get to targeted therapy, immunotherapy, cell therapy is through clinical trials. So we were testing to see what is safe and effective in order to be able to give the patients the best care possibly, and that's possible, and hopefully one day cure cancer, right? That is our goal. We don't want cancer. Clinical trials are always done in phases, so we have to work very slowly in order to determine if what we are giving is safe and effective. There's a lot of myths about clinical trials. So just steps to enroll. So a patient can ease as long as they meet the we do not give placebos in cancer clinical trials. It is not ethical to not give a patient any treatment. So a lot of times what we are doing is comparing current treatment standards to new treatment standards. In a clinical trial, costs for normal care for the cancer treatment are sometimes covered by the company. So sometimes we can find a clinical trial for a patient and they will cover doctor's appointments, they'll cover some of the medications, some of the infusions. And then side effects, it's really hard to talk to a patient about a side effect, especially if it's a brand new drug, because we might not know what will happen if we're testing out the drug. So it really depends on, again, the medication, the dosing, what are we giving? So sometimes we will tell a patient that about all the side effects that can happen which can be very scary, but it is really important that we do good education so that they understand that just because we're talking about all of this, it doesn't mean that all of it will happen. All right. So, real quick about symptom management. So, symptoms of cancer depend on the type of cancer, the type of treatment, as we just talked about, the dose, the patient's history and other medical problems, and what the patient is currently doing to manage the symptoms. So, we will talk to the patients extensively about the symptoms they are having, what works, what doesn't work. Symptoms, as you guys have seen, will impact the entire body. They will have pain. A lot of patients are in pain. And sometimes the pain is chronic. So they might tell us the pain is not that bad because they've been having it for months and months and they got used to it. They can have neurological symptoms like brain fog, memory problems, numbness and tingling, headaches, writing problems, balance issues. They can lose their appetite, their taste changes. A lot of times patients will say, especially after chemotherapy, everything tastes like metal or things taste bland. I don't know about you guys. For me, if I can't have my favorite meal because my taste changes, I would not want to eat. I would be very sad. Nausea and vomiting, diarrhea, mouth sores. They will lose hair. They can have rashes. And we have to think about psychological impacts of all of this. Patients will go through grief. They will be depressed. They will have anxiety. I see a hand raised. Yes.
So I heard a story of somebody who had cancer and they went through treatment, and after they beat it, their hair turned curly. Uh,
Yes.
is that from like the chemo, or do they have like a stem cell change that maybe like altered their like genetics?
So we don't really know what causes it, but once after patients lose their hair from the treatment, sometimes the hair will just grow back. Like the follicle will change. So they will have a different hair texture. So, like curly hair, sometimes they'll have different hair color as well. So, we don't really know what exactly causes it. But yes, that can happen. Good question. Um, So lower blood counts, so increased bleeding and bruising, increased infections, and then organ damage. They can have heart problems, problems breathing because their lungs are damaged, liver or kidney damage. So think about, we're telling them they can have all of this happen. And then all of this happens. They get very anxious, they get very depressed. So we have to have lots of really, really good conversations with them about this and how can we help them through it and what can we do. So we can have non-pharmacological interventions like integrative medicine, which combines medications with CAM, and CAM is complementary and alternative medicine. So the things that we normally think about is non-pharmacologic, like music therapy, distraction, hypnosis, meditation, exercise, diet changes, moisturizing their skin, counseling and support groups. We try to combine that as best as we can. So in the hospital, we actually have an integrative medicine team. They will come, we have a guitar player, we have a harp player, they'll come and talk to the patients. We've learned through different research that the best way to prevent and manage fatigue is exercise, which feels counterintuitive. If you're fatigued and you're tired and all you want to do is lay in bed all day, but we've actually found that it's doing the opposite of that helps the most. We're guys like lifting a huge amount of weight at the gym, but even just walking around the block for 15 minutes will help with that fatigue. Have used medications to help alleviate the symptoms. But we have to be very careful because those medications also have side effects. So we're creating more side effects that potentially we then have to manage again. So we have opioids that we can give for pain, steroids, as you've seen, anti-nausea medications, cannabis. We do have medications that are a form of cannabis to help with appetite and nausea. Antihistamines like Benadryl for their rashes, anti-anxiety meds, antibiotics, bowel regimens, and then, antidepressants if we need it. And sometimes the other thing to understand is we might give a patient a medication for a different reason than what it is normally prescribed for. So we will sometimes give a patient an antidepressant or an antipsychotic, but we don't give it to them because they are depressed. We give it to them because we have found that it helps with nausea. So again, very important to have really robust education and communication with the patients, because they will see something and they will Google it and be like, why are you putting me on antidepressant? I'm not depressed. And we have to have those conversations with them to say that that's not why we're doing it. And then palliative care. Palliative care is near and dear to my heart. And this is something that is not talked about enough. And if there is one thing that you take away from this presentation, I want you to take this slide away. If nothing else, take this with you. Palliative care is specialized care that provides patients with relief from symptoms. When patients hear palliative care, they think of hospice. They think of end of life. And hospice is a small category of palliative care. Palliative care assists with improving the patient's quality of life, with freedom to make their own decisions, with symptom management, psychological care, social care. It is so, so important. And it is something that we should start for any serious illness as soon as the patient is diagnosed. And we can use it all the time. When we are talking about managing a patient's pain, we are doing palliative care, and the patients don't even realize that that is palliative care. And there's so much negative connotation with this. And we don't want there to be negative connotation. So a lot of times we will call it supportive care. That's another name for it, because it has more of a positive tone. But I really want people to understand that palliative, if we talk about palliative care, it does not mean that we are giving up. This is just to make the patient feel better while we are doing everything we can and give them the best care possible based on their goal. And it really is talking about their goal and giving them as much autonomy. When it is time to transition a patient into hospice, and a patient goes into hospice, part of palliative care after the patient passes away is bereavement care. So that hospice will care for the caregivers. They will take care of the patient's family if the family needs it after the patient has passed away. So they will check in with them, they will do support groups with them, they will do respite care during hospice. So if the patient is on hospice and the family member says, I'm really tired, I need a break, the hospice will help them get that break and take care of the patient. So this is an extremely important aspect of healthcare that more people need to learn about and understand its true impact. So early palliative care actually increases life expectancy. So again, it feels a little counterintuitive because a lot of people think of palliative care as care for the dying. But we have found that the earlier we start this, the longer the patient lives, because we are managing their symptoms, we are controlling their quality of life and improving it, we're controlling the autonomy that they want, we're giving them control over their body. It decreases unnecessary hospitalizations and costs, and it helps with so many different aspects of care. So not just physical symptoms, but psychological, social, spiritual, religious, ethical, and legal. And like I said, hospice is just a small subset of palliative care. During hospice, our goal now shifts to patient comfort instead of caring and curing the disease. So the patient got it treated, and they got their last treatment, and usually after they get their last treatment, we let them ring the celebratory bell and we say, woo, you're done, it's so exciting. And now what are we going to do now? And there's a lot of patients that are like, oh my God, what am I going to do now? So we're going to talk about survivorship real quick. Survivorship is anyone living with cancer from diagnosis to end of life. As soon as you get diagnosed with cancer, you are a cancer survivor as a cancer patient. We have 18.6 states. And we think about all aspects of their care when we talk about survivorships. Normal. Now they are like, oh my God, what do I do now? I don't have to go to the infusion center every day. I don't have to go to radiation every day. What am I going to do with my life? The side effects do not go away as soon as the cancer treatment is done. And sometimes the side effects can last weeks, months, years. The patients can have a lot of emotions related to their cancer. They can have survivor's guilt. They can be anxious. They can be sad. They can be depressed. They can be scared that the cancer is going to come back. They're always kind of looking around, waiting for the other shoe to drop. They're worried about the future. They're worried about medical bills. They're worried about going back to school, going back to work. How do you move forward? How do you tell a future partner the history and that you had cancer? Or they're worried about future appointments. I really like this meme because this resonates with a lot of patients that I've talked to. They'll come back and they'll visit us and they'll be like, yeah, every time I get good news, I'm like weirded out by it. And so, like I said, we can have late-term side effects. So the patients can have side effects that last years sometimes. They can have pain. They can have fatigue. No matter how much rest they get, they're going to feel exhausted. They will have brain fog. They will have difficulty with memory, focus, task completion. So we have to retrain them. You're now going to do everything a little different. Maybe we have to have a task list, a reminder list, set alarms for everything, whereas before they didn't have to do that. They might have to write, bullets or have a pen and a pad of paper in every room in their house so that they can write everything down. The other thing that is really scary is secondary cancers, and especially for younger patients. So the patient got cancer, we gave them chemo, we gave them radiation, and one of the late-term side effects that we talk to the patients when we talk to them about their treatment is the fact that they can have a second different cancer later on because of the chemo and radiation that they got. And that's really scary and that's really anxiety provoking because, now again, we're waiting for the other shoe to drop. And we've had patients come through, they got cancer when they were younger, that cancer got cured, they found their new normal, and then 10 years later, 20 years later, 30 years later even, they get diagnosed with another cancer. And oftentimes that second cancer is harder to treat because we've already given them some kind of chemo or radiation. And then a big thing, and again, especially for younger patients, but this is important for every patient, is sexuality and fertility. So this is something that we should be talking to the patients before they start treatment. A lot of cancer treatments, especially chemotherapy and radiation, can lead to infertility or sexual dysfunction. So it is really important for us to talk about those risks. And if the patient is of childbearing age, we should talk about what their plan is. Do they want to try to do any kind of fertility preservation before we do treatment? And sometimes it's really hard because sometimes we have to give them chemo urgently and we can't have those conversations. And that's really sad to think about the fact that we potentially got rid of of something that they may have wanted. If the patients are eligible, if their cancer is a little more stable and we can wait a few days, we can try sperm banking, or we can try egg freezing. The problem with egg freezing for female patients is that takes at least a month. You have to go through a month of hormone therapy and then harvest the eggs and then freeze the eggs. And a lot of times when a patient gets diagnosed with cancer, they do not have that time to wait and not get treated. If they have that time and their cancer is stable, it is absolutely something that they can do and should discuss with their medical team. But then sometimes when we have to go and give, treatment right away, we can't wait because if we wait, the patient can die. We can do something called ovarian suppression for the female patients. So we can give them medications that will stop their ovaries from producing and releasing eggs so that hopefully we are preserving that fertility so that after treatment, we can start that back up and the eggs will not be harmed. During treatment, patients need to avoid pregnancy intercourse, or breastfeeding. If we're giving a patient cancer treatment, especially if it's are harmful, they are harmful to the fetus, and they would only. And when a patient gets chemotherapy, it's in their blood and it is in their sperm or in their semen or in their vaginal fluid. So it can be transmitted to a sexual partner. So it is very important that we have those conversations with patients and explain why they need to avoid this and the harm that could happen if they don't avoid it. Patients themselves can also be harmed. They can be more prone to infections, trauma, or bleeding during sex. So we have to, again, to have those conversations and explain to them that it's important to have to wait. And sometimes there are time frames when they can do and have sexual intercourse, and can be more intimate with the partner. And I do want to also make sure that you guys understand that just because I'm saying that they can't have sexual intercourse does not mean that they can't be intimate. They can hug their partners, they can kiss their partners, they can cuddle with their partners, they can have intimate conversations with their partners. It is very important that, again, we do this education and really explain to them what they can and cannot do. Female patients may receive medications to stop their period during treatment to prevent bleeding. Because if their blood counts go really, really low and their clotting cells go really low and they start their period, they have a risk of actually bleeding out because their period will be heavier. So we try to stop that period if we can. Sexual dysfunction symptoms include lack of libido, body image changes after they've lost their hair or they have a rash, erectile dysfunction, vaginal dryness, pain with sexual intercourse. And we can give patients medications or lubricants or have those conversations with them about helping with those symptoms for when it is appropriate to have sexual intercourse again. So what can patients do? They can seek out support groups. We have a lot of support groups in the area. Seek out reliable resources like the Ullman Foundation. Talk to a counselor, a therapist, or a religious support group. Continue to talk to the medical team and go to the appointments. Yes, it is embarrassing to talk about the sexual dysfunction or talk about some of the side effects, but it is so important to have those honest conversations so the medical team can take the best care of the patient. If we don't know that there's a problem, we can't help them. And then take care of their body and mind. So relaxation techniques, exercise, again, even if it's just a leisure walk, healthy diet, and surrounding themselves with support people and caregivers. So besides the Ullman Foundation, thank you guys for having me here today. We have a lot of other patient and caregiver resources. We have the American Cancer Society, American Society of Clinical Oncology, Cancer Care, Kids to Heart, Lance Armstrong Foundation. These are just some. This is not an all-inclusive list. There's also the National LGBT Cancer Network. LGBT's population is another population that we really need to make sure gets good education, good screening, so that they have the best possible care. And just because I'm out of high school does not mean I don't have to cite my sources. So those are my references. And I'm all done. What, do you guys have any questions for me? I have stunned them into silence, Andrew. You're welcome.
That is amazing. Anyone have any questions at all? Now is the time to ask. Nothing. All right. Well, if you do have any
We have
questions,
something in the chat.
there we go. Grace, how do you adequately support patients that may not fully understanding of their situation?
That is a really great question. The best way that I have found in my 10 years of being an oncology nurse is to keep having those conversations and to keep having the open forum and allow them to have those conversations. When a patient first gets diagnosed, we throw so much education at them. We talk about everything. We talk about the cancer, the next steps, your treatment, the side effects, what's going to happen after the side effects. And they are in shock. They just heard the big C. And sitting down with them,
Oop, did we lose her?
taking that time out of your day to really truly say to help fill in any gaps that they are their goals. What are their goals? Some or to see their child graduate or they themselves graduate. They may not want to live another 10, 20, 30, 40 years. And we need to respect that. We need to respect their cultural differences. From Sophia, can't read the chat. I'm sorry.
Do you think AI will eventually be incorporated more in the future with cancer treatment and its technology?
Um, I think AI is already getting incorporated. I think AI is, in some senses, helping us with research and precision medicine. I am not on the research side at all, so I can't speak to it. But I will say that AI is being incorporated in education. It's being incorporated in videos that we share with patients. But it is really important if we're using AI that we are still it's not enough to say, oh, ChatGPT is going to write my script for me. As you guys saw, you got to cite your sources and you got to make sure that you have the correct sources and the appropriate ones that are evidence based.
Great questions. Any other questions? All right, I am not seeing anything. Well, thank you. Oh, actually, Peter Zhang. Have you dealt with challenges with patients whose first language may not be English, and explain their situation?
Yeah, absolutely. A lot of our patients, their first language is not English. We have medical interpreters, so we have iPads with medical interpreters in dozens of languages. We also have these phones. They are these blue phones where we can have like a three-way call with interpreters. We have worked really hard to create our education in both English and in Spanish because Spanish is the second most prevalent language that we get. And as I mentioned before, when I was asked about challenges with people understanding, again, it's making sure that they really truly understand and having those conversations again and again. And it is actually our policy that we are supposed to be using an interpreter every time we have those conversations with them. And they are medically specialized interpreters. And we do have in-person interpreters as well if we need sign language or, a more obscure language that the iPads may not have.
Do you think just the general public going to AI for diagnosis and questions about their symptoms kind of interfere with doctors' work in any way?
That is a really good question. I have predominantly worked in the hospital inpatient. I cannot really speak to how the doctors work because by the time they have come to me, they've already been diagnosed. I think AI is a really powerful tool when used correctly. I think I'm on TikTok too. I've actually watched a TikTok video where a girl was showing like slides where she was using the chat GPT asking about a symptoms and chat GPT kept telling her go to urgent care, go to urgent care, go to urgent care. And she went to urgent care and got diagnosed with something and had to get antibiotics. Um, but so I think in that way, if we're using it to say, I have a lump on my breast, I'm scared. What do I do? And ChatGPT kind of says, okay, you need to go to the doctor. And then they follow that advice and go to the doctor. I think it will help us, if anything, hopefully diagnose people earlier, and hopefully allow patients to advocate for themselves. Because we've all heard stories where doctors did not believe their symptoms, but hopefully by being able to use their resources correctly and hopefully using AI correctly will allow them to advocate for themselves, to say, no, like I did my research, I learned this, like please test me, please screen me, or be able to say, okay, I want to go see another doctor or get a second opinion because they have seen what it could be. But WebMD is not 100% accurate, neither is Wikipedia.
All right, great questions. Any other questions? It looks like it's gone. I guarantee I'm going to start talking. Another one's going to pop in. But I'm going to go ahead and close everything out. I want to thank all of you for joining us tonight, and taking part of such a great conversation to learn so much more about the cancer realm. If you do have any questions at any point in time, do not hesitate to reach out. I'm more than willing to forward any questions that you may have.
It froze.
Oh, did I? Can you guys see me now?
I can see you now. You froze on my end.
Okay. But yeah, so thank you all so much for joining us tonight. We really do appreciate it. If you have any questions, again, please do not hesitate to reach out. Thank you, Sarit, for taking the time tonight to share such great information, allowing all of us to get a better understanding of the cancer realm. We really do appreciate it. But I will have everything out tomorrow. Hopefully, I'll have a recap, and we will hopefully have this posted by the end of the week. But thank you all so much for joining. Thank you, Sarit, for joining us as well.
Thank
I hope
you.
everyone has a great rest of your week.
Thank you guys. I hope this was
Thank
helpful.
you.